Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter, as always, at hashtag VoicesInVBC, and follow SPH on Twitter at SPHAnalytics. Today, we're excited to have on the program Miriam Paramore, President and Chief Strategy Officer of OptimizeRx. Welcome to the show. It's great to have you.
Thank you, Matt. It's a pleasure to be here.
We are excited to hear about your work in medication affordability, clinical outcomes. From the podcast perspective, we have a lot of different things and topics that we cover, but this is the first time we're really diving into the drug side of the business, which is kind of strange because it is so overwhelming and so big a part of it. So really excited to have a chat with you today. Before we get started, why don't we talk a little bit, just tell us kind of your history, your background, and what got you to where you are today.
I've been in healthcare for 34 years, and I started out as a programmer, so I'm a techie, and I have a real love for data and information and a real love for the industry and how those two things come together. And I've been fortunate to work in the provider side of the industry, the payer side of the industry, and in the health tech sort of intermediary and services, also in the pharmacy and retail, specialty, and the PBM space, and now with pharmaceutical manufacturers. So I've had in that long career, an opportunity to work across the ecosystem. But the kind of the glue in the middle of all of that is the information that these organizations share in the process of delivering healthcare services, helping patients get healthy, and or paying for the delivery of services, a large part of which is now coming out of the consumer pocket. My reason I still do this after so long is I just really have a personal passion, and my personal mission statement with respect to my profession is to help us improve our healthcare system through the value and the power of information. I've seen a lot of things change. Now this information and data really helps us to drive a lot of the value-based scorecards that are key to provider reimbursement. Thank you again for having me.
That's excellent. Absolutely, and that's a really great breadth of experience across the whole ecosystem. Yeah. That is awesome, and love to have that experience. So when we were talking previously as we were preparing, we touched a little bit on your work with ACA, and I thought it was a great place to start because the Affordable Care Act is a massive piece of legislation, and in reality, the one big piece around the insurance got all the coverage, but there are so many other parts of that, and would love to know your piece of that and what you worked on as part of the ACA.
Oh, thank you, Matt. That was a real joy for me. It's the first time I'd ever worked on a piece of legislation directly. So I've been involved in health policy for over 20 years and spent a fair amount of time going to Washington around the HIPAA initiatives from kind of the way back. And then how those HIPAA initiatives around the transactions for healthcare, the claim and the payment and eligibility and things like that got standardized and then required. That was really the floor of HIPAA. Most people don't know that. The privacy and security got all of the attention. And then with ACA, the insurance reform got all the attention, but there was still a lot of other stuff in there. So back with HIPAA, there was a big part of it called administrative simplification, and all that kind of just carried over. And then when we then had sort of an electronic infrastructure for filing claims and getting away from paper and faxes as it was 30 years ago, it really took us about 25 years to get everything off of paper, electronic filing of claims, but we still didn't have the electronic payment of claims. And so you and I, when we get paid by our employers, I'm pretty sure we get paid direct deposit, right? I mean, you don't get a paper check.
Right.
Payroll
it would be
check
hard to imagine
to your house.
Right, in this day and age, waiting for my check to show up, go to the bank, Yeah.
And so there's probably 0% of our listeners today who get paid by a paper check. Yet, just 3 or 4 years ago, there were about 50 to 70% of all checks from insurance companies to healthcare providers for the payment of service delivery was still paper. And so in the ACA, there was this follow-on to the administrative simplification which was all the stuff we should have been doing to get efficiencies in administrative ways in healthcare, but we still weren't doing. And so one of the things that I saw in the company I was with at the time, which is now called Change Healthcare, but at the time was Envion, was we did a little study on how much money we were spending/wasting as an industry by printing paper checks out of insurance company computers onto a piece of paper and then mailing them in the mail so that they could be re-entered into computers that were at provider offices and then re-entered into computers at banks. That was $11 billion a year of pure waste in labor, time, paper, all of that. So we asked and went to Washington, and we're kind of like active citizens. It was so exciting. And said, hey, guess what? If we required this, if we required electronic payment, in other words, payment by electronic funds transfer instead of a paper check, we could save healthcare as an industry just on an expense basis, administrative waste, $11 billion a year. Could we get this into the law and make it a requirement? And we were really successful at doing that. We worked with the Congressional Budget Office to score the bill or to score the clause. We worked with lobbyists who helped us get it in front of the Senate Finance Committee and Ways and Means and Health, those that need to approve it to get it into the bill, to the law. And so that simple thing that seems sort of boring, like electronic funds transfer, when you think about the savings, I'll give you an example of how it matters to my heart, is that $11 billion a year could vaccinate every girl between the ages of 0 and 18 in the entire world with the Gardasil virus at full retail price. That's how much money that is.
That is a great,
when you
that's a great way to tie it back to something, right? People on the podcast clearly can't see my face, but when you said that, I was expecting the country, right? Not the world. Wow.
The whole world. So, the Gardasil vaccine, HPV vaccine now that we give to our children, it's a 3-part vaccine, and it just shows you how those dollars that are just wasted could be used on something that's clinical and that improves and saves lives, and can remove some of that access to care by simply reappropriating dollars from waste and inefficiency into care delivery. But that's kind of how we bring it all home. So as we talk about value-based care and as we talk about the value of information there, that administrative simplification, it's not the same, but it's similar in that it's kind of a foundation. So thanks for letting me share about that.
Absolutely, and I love hearing it because it's a great success story, right? And unfortunately, too often we don't hear those success stories that are tied to these pieces of legislation. But the ACA also did another big piece that a lot of people outside of the very tight-knit community that's spending a lot of time looking at this, but it opened and created and funded, I should say, the Center for Medicare and Medicaid Innovation, or is commonly known CMMI, which has really been the catalyst that has launched a lot of what we call value-based care programs or alternative payment models today. Tell us your thoughts regarding drug prices and how they tie into the broader topic of value-based care.
Yeah, thank you. I want to talk about that at a really broad level, and then Matt, take me down to something more specific if I'm, kind of too high up here. But
of course,
most of the time when we talk about value-based care, people think about the medical cost side. There are a couple of fundamental reasons for that. One that's sort of structural around the policy is that these contracts between payers and providers that turn out or to something called an ACO, or these contracts that are just payment mechanisms that are value-based that have kind of scorecards associated with them. A lot of times they're mostly focused on the medical benefit and procedures, and you see like bundled payments for like a total hip replacement, things like that are value-based, quote unquote. A lot of times they do not include the pharmacy spend as part of that contracting. It's just the medical care and procedural care. However, they do include medication adherence as a kind of a check mark or a score that's important in calculating, kind of value-based report cards. So there tends to be a little bit of confusion, and I just wanted to clear that up. There's sort of a difference between how these reimbursement contracts work with respect to drug pricing or drug costs and adherence, and then how the scorecards are kept. So sort of for the purposes of our conversation, I think medication adherence is a key component of value-based care reimbursement for providers. And that's an issue. And I think the way drug prices are set is another issue, which has lots of policy discussion. There's, new administrative kind of proposals about that. There's, should the government be able to set price, all of that stuff.
Right.
But that's also different than what I'd like to focus on with you, which is the affordability of medication with respect to a healthcare consumer or a patient's ability to actually afford the drug. So that's a little bit different than who sets price, and then can I afford it as an individual is different. And then where my incentive to get healthy is completely aligned with the provider is that the provider wants me to get healthy, but also they want to be reimbursed appropriately if I'm doing well with medication adherence. So I kind of said a lot there, but I just wanted to draw that circle.
No.
Does that make sense?
No, that totally makes sense. And I've spent a lot of time over the last 5-6 years paying attention to all these different alternative payment models and everything. And honestly, until we talked the other day, it didn't hit me that, hey, a big component of this, the drug piece, is not baked into this. But as you said, medication adherence is key to being successful in these. And it's hard to adhere to your medical plan if you can't afford the drugs that you're supposed to be taking that helps you stay out of the hospital, readmissions, ER visits, all that sort of thing. So it ties together perfectly when we talk about it. And that was part of what I was so excited about this podcast was, even though we've been in this for so long, it just never was a piece or a component because, to your point, it's not part of the actual program, right? It's not the roles, it's the medication adherence, not how much are you going to spend on drugs or whatever it is. So I love that component. And we all have personal stories and knowledge of people. And of course, it's all over, the media, and rightfully so, of people that can't afford their medication, which is also a great part of this. And it kind of leads me into the next part, which is a component of this, directly relates to being able to adhere to your medications because you can afford it, which is prescription drug coupons. So the prescription drug coupons, right, a lot of us have seen they're out there. And I can tell you from my experience, or my thought process was, hey, that seems too good to be true, right? I'm supposed to have to pay $300 for this. I get a coupon. Now it's, $20, whatever it may be. How's this going to hurt me that I can't see, right? And then after talking, I was like, wait a second,
too good to be true.
This is legit. It seems too good to be true. Yeah. So tell us a little bit how that works and why it's not too good to be true.
Yeah, it's fascinating because I was saying earlier, I've been in healthcare for 34 years, but until about 3 years ago, I really didn't know about this couponing world, this manufacturer-sponsored coupons. There are also vouchers, which can be used if you're in Medicaid, but I'll just kind of use that financial assistance, if you will, that's made available by manufacturers. So if you think about sort of what's happened in kind of the life sciences and drug development sector, and we'll tie it to reimbursement, there's just a couple of things. First, there's a huge shift from branded drugs to generic, right? And about north of 85% of all prescriptions written are for generic drugs. So most prescriptions are already for generic drugs, and people generally think of generic drugs as cheap, and they are cheaper than branded drugs generally. However, even the price of generics is continuing to increase, so it becomes hard to afford. So there are coupons available from both manufacturers of branded drugs and manufacturers of generic drugs. So, people still have to make the drugs. There are some companies, our partner is Single Care, but there's a company called GoodRx that a lot of people are familiar with that give you coupons on generics, and they show you the difference in price variance based on where you pick up that med. And that can vary from like $10 to $90 across town, depending on what pharmacy, just for that, but it's exactly the same generic drug. So just because generic doesn't mean it's cheap. Okay, and there are coupons available there as well, which we distribute to doctors and to patients through our company. Manufacturers who manufacture branded drugs, Gardasil is one that I mentioned. There are others that you would know the name of for various eye disease, kidney disease, diabetes, heart, all of these big ones. And so what they do is they're trying to avoid the patient, they're trying to solve the problem of the patient saying this costs too much. And they do it as part of their promotion of their own product, which is the drug that they're trying to sell. And most Americans don't redeem coupons for anything, frankly. There are a lot of coupons, but they're not really redeemed at a very high rate. So you can argue whether or not a coupon is helpful, but you're certainly not going to use it if you don't know it's there. So there are more than $7 billion with a B of manufacturer-sponsored coupons made available every year. Only about 10% of those are actually redeemed. And that's amazing to look at how much money there is on the table for patients to use to afford medication that's not used. Why isn't it used? So the reason it's not used is because people don't know the coupons are there. It is mentioned in the TV ads. There'll be very fine print, like there's some financial assistance, and it's probably somewhere on their website. But when people are sick, they don't know to look, they don't have the energy to look, they don't have the wherewithal. So what we do as a business, and this isn't really to be a commercial, but what we do is we distribute those things electronically, again, moving information throughout the healthcare system so that when the patient is with the doctor and the doctor prescribes the medicine, they're using their electronic health record software to do that. And they're prescribing it in the e-prescribing module. So our software just sits behind the scenes and just pops up and says, if you prescribe drug A, they ping us and they say, hey, is there a coupon for drug A? And if there is, then we pop it up on their screen. So the doctor can tell the patient, hey, here's a coupon for what I'm about to prescribe for you, and then text it or email it to you or print it for you. This way we have the doctor is aware and the patient is aware. So that's our big service, is to mobilize this knowledge that these coupons even exist for patients.
Right. And the fact that you got it at point of care is the key, right? Everything, all of us have been in this business for a while. Everything is, if you can't get it right there at point of care, your chance of success trying to leverage that data just drops off a cliff, right? So that's really awesome and a great way to make it happen, because I agree. Much like myself, right? I see the commercials for GoodRx and the other services, and I'm just like, yeah, right, whatever, and I move on. But when your doctor or your careger says right in the office, this is legit, that changes the whole dynamics of it.
It is. So they hand it to you, and then you're more likely to get it filled. And if you get it filled, then that's the first step to adherence, right? And so then there's now an electronic means to link you to refills, and every time you get a refill, you get the same discount. You get the coupon gets reapplied every time you get the thing refilled. And that's how manufacturer coupons work. Up to a limit. So, some of them might be set at, a $500 limit, but some of them could be $1,500 or whatever. So they will offset your copay, and or they will give you, a certain amount of money towards the drug. So who loses in this equation? Well, certainly the patient wins, the provider wins. And from a value-based care perspective, this really goes to patient satisfaction or the patient experience, because not only is the doctor giving me some medicine that's going to help me feel better, they're also helping me save money. They're thinking about how this costs me money to get well. So it's a really, really, really good thing.
So one of the things I wasn't necessarily thinking of is the patient experience portion of it, right? It helps save money and it helps them adhere to their medication. But as we know, value-based care is moving more and more toward patient experience being a part of the, scorecard. And that's a great point.
Right.
This ties directly to that. It's one, financial, but two, hey, they're looking out for my best interest, right? It's going to be a better experience across the board.
Yeah. And we did have a survey recently we have a panel of MDs that we talked to about this stuff, and we interviewed about 1,300 doctors, and about 75% of them said that they believe it's their responsibility to talk to their patient about the cost of care, including the cost of their drugs. So doctors are eager for this information so they know that and they can help. And then if they have access to savings opportunities, they can help with that as well.
And that leads into the next piece I want to talk about. Big component of the challenges within healthcare is the lack of transparency around cost, right? And that also extends to the prescription side of things. It's here's your prescription, and as we all know, going through it, you don't really know what that's going to cost you until you show up at the desk there at the pharmacy. And depending on people's experiences in life, just that could be anxiety inducing, right? I don't know what this is going to cost. I don't know if I'll be able to afford it, let alone the potential, social stigmatization or aspect of I might be standing around a bunch of people. They say, this is going to cost X amount of dollars, and I can't afford it and walk away. Talk a little bit about transparency around pricing and prescription pricing.
Yeah, thank you for that. I want to give a little bit of a funny personal story before I get into the technical side of that. So I had a skin issue a couple of years ago, and I saw my primary care doctor for it. She sent me to a dermatologist, and it was just something that just wouldn't go away and couldn't figure out what it was, some weird thing. She gave me a cream, topical cream, and it came in two formulations. One was a cream and one was an ointment. And all of us that have children know the difference between a cream and an ointment. If we've, diaper rash or, cut some scrapes or, whatever it is. I got the cream filled, and it helped a little bit, but it was like $7 or $8 or something. It was something, it didn't really help. And so she said, well, you know what? It comes in this ointment formulation too, so I'll just switch the prescription. So I go to the pharmacy. It was $300. $300.
Wow.
Because it was a cream versus an ointment. I called my doctor and I said, what? Look, listen, I really don't want this rash, but $300, are you kidding me? $300? And she said, I had no idea it cost $300. Formulation of the drug, if it's an ointment or a cream, if it's a pill or if it's an injectable, makes that much difference. And I'm telling you, it was the same. It was generic, by the way. It was generic, both of them. It was the same exact thing, just formulated differently. But the point of that story, and so I didn't get the $300 cream. I went a different direction, or ointment. But the point of that story is my doctor, who prescribed both of them, had no idea what either one of them cost. None. Neither did I. I made the assumption that generic cream, ointment, it might be $8 instead of $7, but it's not going to be $300. So, and that happens
logical
all the
way
time.
Of thinking, right? Yeah.
Happens all the time. And I see people standing in the line in the pharmacies and they're struggling. And I know that from a medication adherence research perspective, it's, 30% of people in our country don't take their medicine because they say they can't afford it. And there's something like a 50%, so that's, they don't ever get it to start with. But then after that, there's something like a 50% drop-off rate if you get it the first time because you feel like, oh my goodness, I'm going to die if I don't take this drug. And then you realize you're not going to die, and you start to feel better, so you don't get it refilled. So you're non-adherent, so you end up back in the hospital or whatever. So it's all related. And then the point you made about the stress that it puts on you, it's stressful. It could be embarrassing. It can induce shame. It has all these really negative psychosocial consequences because of this affordability, sort of issues. So what I think is really important around drug price transparency, which is a different thing than so it's price setting that we talked about.
Right.
And then what is the price? So it's price transparency. And then is there anything that you can do to help me as a patient with my price or my cost? And we talked about, couponing as a way to help with that. But there are some innovations in price transparency that have to do with my sphere of the world, which is data and information. And about 2 years ago, the real-time pharmacy benefit check is a electronic transaction that became available. And 20 years ago, it became available on the medical side, which was the eligibility check that was part of the HIPAA stuff that we talked about earlier.
Mm-hmm.
That would be where you go to a doctor and they say, hey, does Miriam, they always ask you to give them your insurance card. And this is an electronic way of checking your insurance real fast when you're in the doctor's office to check in or you're in the hospital. Well, we didn't really have that on the pharmacy side until about 2 years ago. And it wasn't until last year that it became mainstream because it was standardized. The NCPDP organization sets the standards for data around pharmacy data. So it was standardized. So every EHR and the pharmacy systems and the claim systems could all be the same. And that basically is saying Miriam is covered by United, and United has, she has this pharmacy benefit, and she has this kind of copay, this type of a deductible, and then here's the formulary. So if you prescribe a drug, it can immediately come back and say it's on formulary or it's off, and here's Miriam's copay, and here's the price of the drug. So it says that. Well, that information is in the electronic health record now. The doctor can see it. This is the first time that it's really been available at scale. So
that's awesome.
That's very, very important. It's very important. Now we're in the part of the cycle where the data is available, but does anybody look at it? The doctor has 7 to 8 minutes with a patient if they're in an office setting. Are they conscious enough when they're looking at the chart, when they're talking to the patient, to look at that little box of information about the cost of the medication? We have awareness and we have training that's happening now, but at least the data is available, so there's a chance to be transparent.
Right. The first step is done, and like you said, now it's changing behaviors.
Yes, exactly.
That is great.
That's right.
I love your story because it's a perfect example of what we were talking about, right, and personal experience of it. Thank you, Miriam, for joining us today, and thanks to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInVBC, and be sure to follow SPH on Twitter at SPH Analytics. Till next time, have a great week.